So it's not uncommon to have seizures, but the majority of those babies don't have epilepsy, and they do not really need anti-seizure medications after their discharge.
Fellow Homo sapiens, my name is Torie Robinson and welcome back to Epilepsy Sparks Insights. Now, anyone can experience acute symptomatic seizures, and in fact we did speak about them in adults with epileptologist Klaus Seriad from NYU Langone Health earlier this year. You can check out our fabulous chat just over here. But today we are hearing from paediatric neurologist Maria Gogou about acute symptomatic seizures in children and babies, the potential causes and how to treat the seizures, when to wean the child off of the anti-seizure medications. And Maria also includes some great tips/guidance for neurologists who are not overly familiar with this type of seizure or the rare epilepsies as a whole. Please don't forget to share your thoughts on this episode with us in the comments below. Like the episode and do subscribe so that we can educate and empower way more people affected by the epilepsies and also clinicians with patients who have an epilepsy so that they can provide the best care possible.
So my name is Maria Gogou and I'm a pediatric neurologist trained in London at Greater Ormond Street Hospital and at the Evelina Children's Hospital, with a special interest on complex and rare epilepsies.
Okay, well, everyone look up this cool paper, Anti-Seizure Medication Reduction and Withdrawal in Children with Drug-Resistant Epilepsy After Starting the Ketogenic Diet. Whew.
It's published in Developmental Medicine and Child Neurology, so they can have a look at this. And actually, this work we made in this field inspired us to go one step forward and looked at another group of patients who have seizures, but they may not really need anti-seizure medications for long. And I refer to patients who experience acute symptomatic seizures. So it's very briefly seizures which happen in very close temporal relationship with an acute insult of the central nervous system, like a stroke or a trauma or some intracranial bleeding or a metabolic disturbance. So those patients experience seizures, but in fact there is no background of epilepsy. So the likelihood of seizure relapse in future is quite low, and they do not usually develop epilepsy. So in those cases, sometimes we have to start a medication during the acute phase just to cover them and prevent from more seizure activity, within the first few days after the insult. But in most of those cases, there is no need actually for long-term anti-seizure treatment. So this is something we wanted to look at in our trust and see what's happening in those cases. And we realized that there are no established guidelines actually about how long those patients should be kept on anti-seizure medication treatment. This in part can be due to the different etiologies which can lead to acute symptomatic seizures. But this can also be related, to factors associated with the hospital care, like, as I mentioned before, changes in medical cover and unplanned discharges and transfers of patients. So we decided why not doing a quality of improvement project and try to reduce variability in our everyday clinical practice. So what we did is we tried to educate hospital staff about acute symptomatic seizures and increase awareness of this condition. So we launched some educational videos and created informative posters for medical wards. We started delivering one-to-one training sessions to medical and nursing staff from other wards beyond neurology, like intensive care units and renal or oncology and neurosurgery department. And we also created informative leaflets about acute symptomatic seizures for parents of those children to make them aware of what exactly the seizures their children had are and about the fact that they may not really need long-term anti-seizure treatment. And in order to make sure we have sustainability in this attempt, in this project, we have also introduced a smart phrase in all discharge summaries in our trust, which actually the smart phrase is a gentle reminder that if this patient is on anti-seizure medications on discharge, consider if they really need them and work out a weaning plan, talking with their treating doctors. So we're going to audit the results of this intervention and compare the rates of long-term treatment with anti-seizure medication after acute symptomatic seizures before and after our intervention.
And again, thinking about this from a patient and even family perspective, you don't need to be on drugs, right? You want to come off them.
Yes, exactly.
Because of, as mentioned before, the impact of anti-seizure medications, as well as other medications, but in this case, anti-seizure medications can be enormous, like affecting your cognitive function, affecting your mood, affecting your life.
Exactly.
Your whole life and quality of your life. So to be able to get off them would be amazing rather than remain. I mean, I can imagine some people will remain on these indefinitely, possibly for the rest of their lives. And if they could get off them earlier, wow.
Well, this is very important. I would say that a group of patients who often experience acute symptomatic seizures are newborns, babies. So newborns, especially in intensive care units, can have strokes and some bleeding and hypoxia-related events. So it's not uncommon to have seizures, but the majority of those babies don't have epilepsy, and they do not really need anti-seizure medications after their discharge. And one of the medications we use for neonatal seizures is phenobarbital, which is a fantastic medication, very effective and very helpful, but it can have side effects. It can lead to sedation sometimes. So if a baby does not really need this medication, it's very helpful, very useful to be aware of that and try and wean it before their discharge. And actually studies have shown that the duration of the treatment in those cases doesn't alter the outcome.
Oh.
So treating them for longer doesn't prevent the development of epilepsy. If someone develops epilepsy in future, which is the minority of cases, of course, but if this happens, does not depend on the duration of the previous treatment with anti-seizure medication. So it's worth trying doing that. But in all those cases, what I want to highlight is that weaning is a very individualized process. It needs to be very adjusted and tailored to the needs of each patient and to the coexisting problems. For example, when we decide to take a medication off, we need to counsel patients and families. I keep saying families because I work with children very, very closely and update them about any potential risks and the possibility of seizure relapse, of course. We need to have updated rescue plans and make sure they get hold of anti-seizure rescue medications and try and implement the weaning process during a time period which is convenient for family dynamics. So we tend to speak about personalized medicine and individualized approach when we implement a new treatment. But I would say that when we decide to stop, to de-escalate treatment, it's also important to take an individualized approach to things.
You've just made me think of, gosh, I sound like I'm promoting them, but like McDonald's restaurants, they have the processes where everything is the same. Everything is automatic and boom, boom, boom. Everything comes out exactly the same. And it could not be more different for people affected by epilepsy, whether it be children or adults. Everything is so individualized, as you've been saying. Don't treat them like they're a Big Mac. It's much more complicated than that, or much more individualized and personalized.
Exactly, which is something which needs time. You need to invest in this relationship with the patient and meet them in depth and ask questions again and again and be available and open to discuss and reconsider and take steps back and decide again.
What would you recommend to clinicians who are thinking, okay, I agree with everything you're saying, but I'm under so much stress and I have so little time. How on earth do I achieve this? What would you say to that?
I would say that it's helpful to be open with their patients, to set some limits and some rules of communication with them from the very beginning. So it's very helpful to say, I prefer to be contacted during those hours, or I feel more comfortable when contacted by a text message or an email rather than calling me and ringing me. So I would say that honesty is the first step to be done. Now, for clinicians who don't feel very familiar with taking a decision in a special circumstance, because this can happen, we cannot be experts in every field, I would say that it's not bad to discuss complex and difficult cases with other colleagues who may have some bigger expertise in the field. So if we just put patients first and prioritize their benefit, I think we can find solutions. And of course, there are days that all of us feel very overwhelmed with phone calls and urgent issues in the ward and referrals from other departments. I think if our first priority is patient's benefit, I think we can find ways to cope with that. And collaboration is the cornerstone.
I like that collaboration and recognition that it's okay to ask for help, that you're not expected to know everything. I've said this in other episodes where one of my favourite, most memorable moments with a neurologist was when he said, I don't really know the answer actually, but I'll find out. I'll go and speak to somebody else. And I thought, wow, that really built my trust in him because he was honest about not knowing everything. When people pretend to know everything, I'm like, oh, for God's sake, like, of course you don't, and it decreases the level of trust. So I can say from our perspective, I really appreciate it if a clinician says, I'm going to work with other people to try and improve the quality of life of you or your child, and look at it as a long-term relationship too, like you were saying.
And perhaps the less familiar someone is with the situation, the more frequent the follow-ups and the visits and the encounters with the patients can be. So if you are super familiar with an epilepsy syndrome, for example, you can just say a few things in advance. You are confident with the trajectory perhaps the patient will follow or with potential side effects. If you don't feel so familiar, I think a very good way to cope with that is to touch base with the family more frequently to cover for this gap.
Thank you so much to Maria for her professional insight into how to help babies and children affected by acute symptomatic seizures, and for rightly pointing out that the little people affected rarely go on to develop an epilepsy. Do check out Maria and her work on the website torierobinson.com, where you can also access the podcast, the video and the transcription of this episode. And if you haven't already, don't forget to like, comment and subscribe to the channel. Share this episode with your friends, colleagues, family members, and see you next week.